It's 4 p.m. Italian time, so it's time to get started with Food for Veins and Veins for Food. As always, we will welcome 30 seconds to allow everybody to join the platform. So 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and welcome everybody again to Food for Veins and Veins for Food, a not-for-profit educational and humanitarian initiative that always starts with the art of Monica Glowinski, dedicated to the heart of all the health professionals who have been involved in this tough COVID time, to which this project is dedicated to in terms of support of the economic crisis as reported by the call of the Lancet journal on the topic. Nothing would have been possible without a truly stellar faculty and the many friends and colleagues who have joined along the way this educational and humanitarian initiative. I take this chance to deeply thank Professor Santiago and Professor Jindal for their contribution as keynote speaker last Sunday, and also for the extra time they used during the week to answer to all of the questions the audience made. I remind that also today on the audience will be allowed to make questions in whatever language inside the question and answer box. So don't use the chat for the question, use the question and answer box for the questions, and they will be answered live or in written form based on the time availability and the ranking they will have with the likes inside the box. Today we focus on one of the most important topics, I would say, anticoagulation. Today, as always, we will provide international CME credits and also national. And today, as always, we will enjoy truly stellar faculty members and keynote speakers. We will introduce them later on with also some surprises, considering we are coming toward the end of Food for Veins initiative. I take this chance to deeply thank Professor Caprini, Professor Diaz, Professor Liu, Professor Ramacciotti for having contributing also with extra educational material in form of videos you can find inside the Viewin Foundation platform. And I deeply thank once again Professor Caprini, Professor Enki, and Professor Liu for serving as honorary chairs, meaning that at the end of the webinar, as big experts, they will wrap up the concepts everybody should take home, but not before having enjoyed the precious insights of our continental expert representatives who will introduce one by one during the same webinar. Nothing would have been possible without these wonderful colleagues and also the individual and company donors. The companies we defined as the magnificent 7 companies who supported the initiative by means of an unrestricted grants. So thank you, Amnol, Balton, Bayer, Medi, Servier, Sigvaris, Tactile. I deeply thank all of you. I look forward for being on together. And by the way, the t-shirt you're looking at over here is reproducing the face of Professor Caprini and of an important sentence on anticoagulation I will explain you later. I look forward for being together in another food moment dedicated not just to humanitarian support, but also to the social time we were used to share together, and that today we would have shared in honor of Tarun Grover and Roman Taurajinsky from India and Russia, since it would be their birthday. It was actually yesterday, so virtual birthday cake for them. Now I pass the mic to the ones who I consider friends, colleagues, but first of all also family. So Oscar.
Thank you, Sergio. Welcome, everybody. And one more time, thanks for attending our Sunday webinar, which will certainly be a new great opportunity to share science and discussion. Let me mention and say thanks to the women, to the world in phlebology that yesterday held a wonderful webinar showing the female power in science and knowledge. Now, remember, you can make questions in any language, either live or using the question and answer box. Recuerden que pueden hacer sus preguntas en español, tanto en la presentación en vivo como usando la casilla de correo. Gracias.
Thank you, Oscar. Now we fly on the way to California with Professor Chi.
Good morning, good afternoon, good evening, everyone, wherever you may be, wherever you may come from. Today we have two great speakers on anticoagulation, and please enjoy the show. 各位同道们，大家早安、午安、晚安。今天是我们关于抗凝的一堂课。如果您有任何问题，请在我们的 Q&A 项，我们会尽快的给您回答。谢谢。
And thank you so much, Willie, both for being with us at 7 a.m. and for interacting with all the Chinese colleagues. You know that we always start with 1 minute dedicated to a guest of honor, somebody who is not from the Venus world, but who is promoting through his or her professionalism, public Venus and health awareness. Food for Veins started after we read this interesting paper on Lancet that is talking about the redefinition of vulnerability in the area of COVID-19. So today we are honored in having with us a representative of the sustainable and occupational ward. So it's occupational health dedicated to venous and lymphatic ward through Sarah Bradbury. Sarah is working now at the World Business Council for Sustainable Development, and she has previous experiences with the United Nations Global Compact Project. And here is her message.
Good afternoon, everyone, and thank you very much for having me here today as a guest of honor to speak briefly about redefining vulnerability in the COVID-19 era. My name is Sarah Bradbury, and I work in the social impact team at the World Business Council for Sustainable Development. Over the past 9 months, we have all witnessed the devastating health outcomes of a global pandemic and the drastic steps policymakers taken to try and limit the spread of the virus. However, many of the strategies most recommended to control the virus will have even greater adverse socioeconomic impacts if not properly considered. For casual workers who can't work from home, children who depend on school meals to be fed, and those who are vulnerable to domestic abuse, a lockdown policy can reinforce the vicious cycle between poverty and ill health. Policymakers therefore need to reassess vulnerability, taking into account long-term risks of social, economic, and health inequalities in their context. In doing so, we can hope to avoid the reversal of all the advances in sustainable development we have seen over the past few decades. Many thanks again for the honour of being here today. If you would like to find out more about our work, please feel free to reach out to me at bradbury@wbcsd.org. Thank you.
And with this, we deeply thank you, Sarah Bradbury, and we hope that the message has been properly delivered to all the colleagues. Now, we talk about outstanding colleagues, our giants of our field. And to keep always the morale quite up in these tough times, we joke a little bit, coupling them with great figures from the artistic or the sport world or musicians, like we are going to do today presenting Professor Diaz. The metaphor here, the coupling, is pretty easy. I thought about Atahualpa Yupanqui because like Professor Diaz is from Argentina. And like Professor Diaz is a great guitar player, as Professor Diaz showed us in some of our meetings. The third reason I will tell you at the end why I thought about him. Professor Diaz is from Vanderbilt University. We all know his outstanding basic science research skills, but we should also know about his outstanding surgical skill because he's also a surgeon. He is a leading figure in the American Venus Forum. And the third reason for which I thought about Atahualpa is that Atahualpa wrote a wonderful song called Los Hermanos, so the brothers, and he is a true brother for many of us. So it's my pleasure to introduce Professor Diaz and his talk about coagulation. It's important we all know the basics of coagulation to understand at best how to move forward. So thank you for your insight on this topic, Jose.
Thank you, Sergio, for the kind introduction. Good morning, everybody in the United States. Good afternoon in Europe. Yeah, I have no words for the introduction, so I really appreciate that. The title of my talk is Basic Concepts and Basic Science Data, where we must know this was, I was asked to talk about this, and I will proceed with this. Can you see my slides?
Yes, everything is perfect. Yes, Jose.
Thank you. So I have no disclosures. So my role today is to provide basic information to facilitate understanding of this anticoagulation module, and also to provide basic information about deep vein thrombosis. So in order to talk about anticoagulation, we should start talking about what coagulation is. The blood coagulation cascade involves a series of cascade activation of zymogens in a reaction chain manner. The precursor protein zymogen is converted to an active protease by cleavage of one or more peptide bonds in the precursor molecule. 3 pathways were identified in the coagulation cascade, as you can see to the right: intrinsic pathway, extrinsic pathway, and the common pathway. Now, the function of the coagulation system is protective. Injuries and lesions of the tissues occur on a daily basis, and our body reacts against bleeding, forming clots. This is just a cartoon to an example of a lesion. When we have a lesion in the skin, we have bleeding, but the coagulation system, it tries to block that bleeding, and this is the protective function of the coagulation system. Now, this coagulation system have internal regulators, and it's important because when we initiate the coagulation cascade, natural anticoagulant process occur in our bodies, and also we have a fibrinolytic system that try to get rid of the clot. Now, this allows the body to form clot in a controlled manner, and this is important about the balance. Now, if we talk about this balance, these are biological conditions that alter balance, and the regulation mechanisms cannot compensate. So the worst case scenario is increased stimulation of the coagulation cascade, the increase of activity of fibrinolytic system, or even the natural anticoagulant processes. So this is why when we have an increase of the stimulation cascade or constant, anticoagulants play a role. I will mention briefly, because it will be discussed later deeper, but in this case, heparin is one of the anticoagulants, and the action is to bind antithrombin and speeding the binding and inhibition of activated coagulation factor 10 and 2. Warfarin is another anticoagulant, in this case, an orally available anticoagulant that functions by altering the hepatic system of vitamin K dependent coagulation factors, specifically factor 2, 7, 9, and 10. Now, recently, the direct oral anticoagulants were designed specifically to inhibit directly either the activated factor 2 and 10, as it will be described in the next talk. Now let's touch a little bit on deep vein thrombosis, and a disease that anticoagulants play a big role. As a definition, deep vein thrombosis refers to the formation of one or more blood thrombi in the deep vein system, most commonly in the lower limbs. There are complications that we need to understand. Acute complication as a pulmonary embolism, which implies the separation of the clot from the leg formation site, and then travel through the circulation up to the lungs, and the post-thrombotic syndrome, which is a chronic complication, as I will mention later. Now, there are some standard narrative mechanisms involved in the genesis of DVT are attributed to the Burkitt triad, in which involve hypercoagulability, blood stasis, and endothelial injury. Now, also as a standard narrative, we believe that vein valves are important anatomical sites in where the thrombus formation occur. Now, deep vein thrombosis is a big problem, and I will bring some numbers from the United States. The annual incidence of deep vein thrombosis is approximately 900,000 new cases per year, and all of them receive the standard treatment. Now, there is a mortality associated with the deep vein thrombosis, and also a distribution. Almost 50% of the patients are associated with a risk factor, but there are patients that not. And in that particular group, the second episode occur in 10% up to 1 year and 30% in 5 years from the first episode. Now, what is interesting for that particular group is that between 20 and 50% of the patients develop the chronic complication, which is the post-thrombotic syndrome. Now, the problem with the post-thrombotic syndrome, as many of us deal with this kind of patient, is very difficult. The quality of life is very, very deteriorated in these patients. And also, is associated with a cost approximately $2 billion per year in the United States alone. So regardless that we have a great treatment, still we have research to do. Now, the mechanisms that are involved in venous thrombus formation and amplification is the coagulation system, but also we need to remember that we have inflammation and the fibrinolytic system as part of the thrombus formation and amplification. There is a lot of literature that we are receiving in connecting coagulation with the fibrinolytic system or fibrinolytic system with inflammation, or even though coagulation with inflammation, which demonstrate the presence of these three systems in deep vein thrombosis or around deep vein thrombosis. As you will see today, anticoagulation therapy is critical, and we are researching about inflammation and fibrinolytic system. If we analyze the DVT current treatment options, you will see that I tried to plot in one slide medical and surgical treatment that we have available today, and how important is the coagulation system in this, because as you will see in the next talk also, the tagging the coagulation system is still important and critical. Now, if we try to talk about the future, we are thinking right now in inflammation and the fibrinolytic system, targeting molecules like P-selectin or drugs like statins are important in the inflammation part, but also in the fibrinolytic system with the power inhibitors that are in development. But I would like to reinforce that still the anticoagulation therapy is critical. So in summary, deep vein thrombosis is a very important health issue. Anticoagulation therapy remains the main treatment option, and improving anticoagulation treatment will be part of the future, and also looking for new options. Thank you very much.
And it's us deeply thanking you. I wish you could hear all the people clapping. We are a lot from all around the world, so I take this chance on to also to thank all the ones who are joining us today. Now, as always, we start with the World Scientific Round. This means that we have top experts from all around the world representing the different areas. And we start big with Professor Antignani. It's my pleasure to introduce Pierluigi. He's the current president of the International Union of Angiology. Pierluigi, the mic is for you for making a question to Professor Diaz. Unmute yourself.
Okay. Thank you, Sergio, and compliments for the very clear and complete presentation. We know that the heparin have also an anti-inflammatory action. What do you think about the oral anticoagulants, new and old, have the same action or not?
Thank you for your question. It's absolutely true. There are literature referring of the anti-inflammatory properties of heparins, and this is absolutely true. Now, regarding the new anticoagulant, oral anticoagulants, if that is your question for the DOACs, we will see in the future, and it will take approximately 5 to 10 years to see if there is an impact in the anti-inflammatory association too. And why is that? What is interesting is that post-thrombotic syndrome is really associated with the inflammatory part. So I hope the new oral anticoagulants have also properties like that. And as I said, I think the window for us is to see what happens with the post-thrombotic syndrome on patients under direct oral anticoagulants in the future.
And I deeply thank Pierluigi and Jose. And now we fly all the way to Mexico, and it will be Professor Bottini introducing the continental expert representative. Oscar?
Thanks, Sergio. Let me introduce Dr. Alejandro González Ochoa from the Mexican Albino Forum. Alejandro, go ahead.
Thank you. I really enjoyed your talk, Dr. Jose. It can be sometimes intimidating for us clinicians when you talk about inflammation and population. We all see these all numbers and all these capital letters, and we sometimes get scared when we see them. How do we get involved the younger generations in keeping with the studying of basic science for developing future research?
I can talk about my personal experience. I was motivated to basic science from the very beginning. I participated in University of Buenos Aires, where I studied, tried to teach and develop some science in Argentina. I think the motivation is with us, but as far as we get all in the profession, we get busy in the activity, in the OR, and it's difficult to put two things together. So if I have a message for them is that don't quit, keep going, try to read. And also there are, and this is a message for all Latin American and every country, I would say around the world, but my heart is a little bit Latin American, right? It's a message for the young physicians that there are collaboration, not in this COVID time for personal collaboration, travel around the world, but laboratories at least in my laboratory is open, and many laboratories are open to, try to connect with the young people and try to interchange information. Visiting, or in this case, this platform can help a lot. So the bottom, probably the bottom message will be, or the idea is that keep going and move forward with the interest that we will try to connect and help each other.
Thank you so much, Alejandro. Now we fly all the way to United States. Thanks to Professor Chi, we'll introduce the next continental expert representative, Willie.
Yeah, next we have a good personal friend and a good friend to VWin. Everybody's familiar with Dr. Kilani, who is the current president of the AVOS Foundation. Neil?
Thanks, Willie, and thanks, Sergio, for inviting me to speak. I've had the pleasure of getting to know Jose Diaz over the last few years, and it probably comes as no surprise to you that Jose is very passionate about the value of preclinical science to add to our evidence base before moving to clinical trials. And so the question I have for Jose is, when considering coagulation and phlebology together, what question do you find most interesting right now? If you were unbridled from all your other professional responsibilities and could focus on research, mentoring, teaching, things that you love, what project would you want to take on? How do you sort of construct that? How do you see how that kind of project would be built methodologically, and how do you see the impact of the outcome of that work on clinical practice? And thank you for a great talk.
Thank you, Neil. I really appreciate your words. It's a big question. I mean, a very important question. I will try to say that improving the treatment that we have today, as we are doing with the coagulation system and anticoagulation, is important, definitely, no doubt. But I will open seriously, as many laboratories are working right now, the focus on the inflammation and the fibrinolytic system. I have the fortune to work with, be trained in a laboratory that Dr. Wilfie was targeting P-selectin for so many years, and there are options open right now. So I will say that my enthusiasm right now is see what happens with the statins, for example, that is already an approved drug, and see what it would be the future for that. And keep going in the investigation of molecules as P-selectin, as galectin, and also try to tag PI1 with PI1 inhibitors. I think I put those in my slide. So I hope, I can see an improvement on the post-traumatic syndrome numbers that we have today in the future.
Thank you so much, Professor Kilnani and Jose, for the contribution. Now it's my pleasure to fly all the way to Singapore for the one I consider not just my squash trainer, but also a trainer for all of us in the venous field, because he's really a great mentor, and I really take this chance to invite all of you to attend one of his meetings in Singapore, because his expertise is significant for real. Professor Sriram Narayan, the mic is for you.
Thanks very much, Sergio, and thank you again, Jose, for a wonderful talk. It's really nice to see someone who's both a surgeon as well as a basic science expert, and thank you for emphasizing the importance of anticoagulation. Sadly, I don't know whether I should say sadly, most of the anticoagulation guidelines are physician-led, be it the American College of Cardiology or ACCP or ESC. And they suggest that thrombophilia testing is not routinely necessary. That has remained the guideline. But we have moved to a world of intervention, be it in acute DVT or in post-thrombotic syndrome. We are leaving stents behind, and a rethrombosis really means a re-intervention for us. And we also now know that the DOACs are not very effective, especially in patients with APC resistance or antiphospholipid syndromes. Would you then suggest that thrombophilia testing should now become standard practice if we are going to plan a deep venous intervention, be it after acute DVT or be it for a patient with post-thrombotic syndrome? And should thrombophilia testing guidelines now be changed?
Thank you for your question. Yeah, it's clear. Thank you very much for your question. Yes, so I think the matter of fact that we have guidelines are important to organize the therapeutic options that we have. So I would like to be very respectful with my comment right now. Yes, there are particular cases in where, yes, thrombophilia testing are really important. So I think it's important to have the guidance. I think it's very important to have organized the information, how we will handle to the patient. But at the same time, as a physicians, we need to make sure that each patient represents each one case in particular, and sometimes we need to evaluate in that particular scenario what is best for the patient. So the guidelines are guidelines, very important, guide us, but at the same time, at the time that we need to put that in practice, we need to remember that the patient is a particular case, and maybe those patients deserve thrombophilia testing. So no attacking guidelines. At the same time, I'm saying that yes, in each particular case, it could require testing. Yes, you're right.
And thank you so much, Sriram. We hope to be in Singapore soon for one of your initiatives. So now, Jose, we thank deeply all the Continental expert representative for this World Scientific Round, and we focus on the audience. And we start from Dr. Dumitru Casian, who has been asking you now, what is your opinion about the role of antiplatelet drugs in extended treatment, secondary prevention of venous thrombosis?
Yeah, I mean, it's in a study right now. There are clinical trials, and there are information in both sides. From the basic science, we know that the role of platelets, when the thrombosis process is initiated, is questionable. However, in thrombus initiation, we demonstrate and we publish that it could be a particular role for platelets. So whether we need to decide in the future, the importance is in a study, and we will see, I hope, soon.
Thank you. Now we fly all the way to India with Professor Rahul Jindal. We take this chance to deeply thank him for the outstanding contribution as keynote speaker last week, and also for answering to all the questions already. So he's asking you, how will the statin affect the treatment in future, and where we have reached in terms of the literature?
Can you repeat the question?
How will the statin affect the treatment in future, and where we have reached in terms of literature? So the role of statins in coagulation. And
so thank you for the question. The statins is something that is really interesting. As I said before, we know exactly that their side effects. We know the drug we use, it is approved. And what is interesting at this point, the literature suggests that yes, there are an inflammatory property of statins. There is a renin system activity for the regulation of PAI-1, how it acts on PAI-1. So this is what we have. We have evidence in the basic science. Now, putting this in patients, there are many questions that we still have. For example, what is the ideal candidate to receive statins? When we should initiate statin, if the statins are so beneficial as we are seeing in preclinical models. So we are in this phase between T1 and T2 of translational 1, translational 2 research, in where we will see what happened. There are clinical trials in progress right now. Particularly, we in our laboratory run experiments and we demonstrate effects on preclinical models. So the data is out there, is important, and doesn't matter the models used in the preclinical models, doesn't matter the statins that were tested in the basic science arena, and doesn't matter the models that were tested. Always anti-inflammatory effects were observed and reduced in the thrombus mass was observed. So it's very promising, I will say, but still we need to go. We need to move forward some points in this particular matter.
Thank you, Jose. Now, next question is from Dr. Andras Eros. Thanks for this excellent lecture. In your opinion, what are the best, oral or endovenous anticoagulants, I guess he means, in DVT patients? Maybe you want to add also subcutaneous.
Yeah, I mean, of course, we have limitations in the way that we need to use the anticoagulation. I will prefer to have oral anticoagulation if I need anticoagulation. And the situation is how we balance, but this happened in all the process. So yes, I'm pro-oral, and our research, for example, in preclinical models, try to be oral as much as we can, yes.
And Dr. Passariello, Fausto, friends of many of us, is making more a comment, I would say. Another complication in DVT is a chronic pulmonary hypertension, which can be a late complication as is the post-thrombotic syndrome. Would you like to comment as well on this comment?
Well, it's a little far for the area that we investigate. We are focused on deep vein thrombosis of post-thrombotic syndrome. So probably I will not be the most appropriate to answer that question.
Sorry, I lost you. Who do you want to answer for this? What did you say?
So I said that our research is more on deep vein thrombosis and post-thrombotic syndrome, not much on the arterial, on the pulmonary artery side or complications for that. So probably I will not be the best person to answer that question.
Well, we have a secret weapon for sure in Professor Ramacciotti. So I would ask Eduardo if he wants to jump in. Eduardo.
Yes, can you repeat the question,
yes,
Sergio?
It's not a question, it's more a comment from Dr. Passariello. Another complication in DVT is chronic pulmonary hypertension, which can be a late complication as, for example, post-thrombotic. So maybe we could comment a little bit on the kind of prophylaxis we can do, or if there are like some drugs that are acting more also on prevention of chronic pulmonary hypertension. Is there something we can say about this?
Yes, what we can say is that treating with the anticoagulation strategy we have created with DOACs, we have decreased I wouldn't say significantly compared to heparin, but it works. But we have never impacted the development of chronic pulmonary hypertension in patients that develop pulmonary embolism. So it's a different strategy. When we're working in treating the acute episode, we're trying to avoid as much as possible recurrences. But we have a little bit of close to zero effect in those who have pulmonary embolism and doesn't. So it's a different strategy, different treatment for chronic hypertension. We have tested DOACs and they failed horribly in treating once the hypertension is already established. So we have different targets. We have different things to deal with these patients.
And thank you, Professor Ramacciotti. We'll take out one of your next questions since we already use you now. Thank you so much. And now the last question for Jose from Italy. Let me translate this for you from Dr. Maria Pariselle. She's asking you, Jose, in the choice of the oral anticoagulants, between old and new generations in patients who must follow the treatment for a long time. Are there any data about the psychological component, like the emotional component of the different drugs used?
I don't have any information about that.
Me neither. Do you have some information, Eduardo, about this?
Can you repeat the question?
Sure. So the question is about the emotional component with the different drugs. So how the patient is perceiving that emotionally, if there are like an investigation looking at the psychological component of taking one type of drug rather than another type of drug.
Oh, what we did is quality of life, Sergio. And something related to quality of life we did, but I'm not aware of emotional impact of these drugs. But I'm aware of inflammation of thrombosis and depression-related research. So are people taking a look at the effect of anticoagulation in depression and the correlation between those biomarkers and stuff like that? But I'm not aware of any emotional evaluation rather than quality of life.
So thank you so much, and maybe food for thought for future studies. So at this point, we deeply thank Professor Diaz and all the ones involved in this first part. We are hundreds and hundreds, so deeply thank you, Jose, and we'll catch you with you at the end of the webinar. And now we can stay with Professor Ramacciotti, and indeed, if I have to keep on doing metaphors with great figures from the artistic world, it is pretty easy for me to think about Gaetano Veloso, since Professor Ramacciotti is a great guitarist, but also a great bass player, as he showed us during the IMAP meetings. He's from Brazil, but he's also an honorary professor at Loyola University. Whoever is familiar with PubMed knows his name because he's one of the greatest trialists. And since he's always based on evidence-based data, I took the chance to have a look on what he is putting out there in words about himself in his social network profile. He's writing that he is a drama-free vascular surgeon. He's a professor, he's a scientist, a musician, a writer, a Queen fan, a sports guy, but first of all, in my opinion, is a dear friend and also somebody who really knows the meaning of the word teamwork. So deeply thank you, Professor Ramacciotti, to talk with us today about evidence-based facts on DOACs we all should know. So now please share your screen and start your magnificent lecture.
Okay, so please tell me if you're seeing my presentation. And first of all, it is a pleasure to be with you, Sergio, with Dr. Caprini, with so many friends, and particularly with Jose. We have had the chance to work together in Michigan under the mentorship of Dr. Wakefield, Dr. Comerad. It's a pleasure to see Jose again. And differently from Jose, I have all the disclosures to disclose. I work with the development of all these anticoagulants, new anticoagulants, erratic new cardiovascular drugs. So I have all the possible disclosures to disclose. So you have asked me to talk in 15 minutes what the phlebologist should know about DOACs, and I focused on VTE treatment. I'm not talking about prevention, and I'll take some minutes to discuss what we're doing with the COVID area and DOACs. So what have we learned in treating DVT with the DOACs? Well, we have 5 objectives when we're treating a DVT. Number 1, most important, is to prevent death by pulmonary embolism. Then number 2, to arrest thrombus growth and prevent VTE recurrences. This is important because when we do trials with VTE treatment, our primary endpoint is to reduce recurrences. And it's very nice to have some strategies in preventing valvular dysfunction and reduce post-thrombotic syndrome. And I'm seeing Dr. Peter Henk, who is an enthusiast of that kind of line of research. And in the acute phase, we want to limit the progression of swelling and reduce the symptoms. And I put the number 5, and I think we did greatly when we developed the DOACs, is preventing bleeding. When we're giving anticoagulants, we increase the risk of bleeds, but I think this is the most important thing we have learned with the DOACs. We can reduce bleeding when we use them properly. So when we're doing our trials, we take a look at recurrences and we take a look at bleeds. Well, this is what we show our residents. You can treat your patients with heparin and vitamin K antagonists. And if you do so, you have to do the bridging and have 2 INRs above 2. When you treat with DOACs, they're different. We should not switch between them. And if we're using dabigatran or edoxaban, it is mandatory that we start with heparin or fondaparinux. And if we treat with rivaroxaban or apixaban, we can treat them without heparin, and we can do it even for pulmonary embolism. But you can use also heparin if you want to start with heparin with these drugs. But pay attention, you should not change between them, and you should follow label. This is everybody knows that. And we have created this terminology, initial, long-term, and extension. And I think extension phase changed it after we developed the DOACs, because they work like heparin and vitamin K antagonists, but in the long run, they produce less bleeding. So what have we learned up to 6 months with these drugs? Well, they work exactly like heparin and vitamin K antagonists, but they produce less bleeding. And if we prolong beyond 6 months the treatment, they reduce the relative risk of recurrences around 70%, but without increasing major bleeds. So that's what changed a little bit when we brought the DOACs to the VTE realm. We can prolong treatment without increasing bleeding, so we reduce the number of events. I think this is the most important thing we have brought with our clinical trials for the VTE treatment with DOACs. Okay, so when we look at the trials, all the trials we did with all these drugs, and we combine them in a meta-analysis, we see that we work exactly like heparin and vitamin K antagonists in terms of VTE recurrences. This is good, but we reduce major bleeds. And what kind of major bleeds? Well, intracerebral major bleeds and fatal major bleeds. So that's why we love to treat VTE with our DOACs, because they reduce what scares us most, intracerebral bleeds and fatal bleeds. And the explanation for that is that we have developed these drugs for the atrial fibrillation population. They're more fragile, they are elderly. And when we bring these drugs to the VTE realm, we have younger patients, so we have a pretty much safer profile. And when we break it down between pulmonary embolism, deep venous thrombosis, we keep consistency in terms of recurrences and bleeds. So that's what we have learned with these drugs. And when we take a look at the ACCP guidelines in terms of duration of therapy, I think the new guidelines will change a little bit, because we used to have the cut points of 3 months or 6 months, proximal and distal, provoked and unprovoked, and all these things are going to change in the upcoming guidelines because the new data in extending treatment changed. So as for now, provoked 3 months, but if it is a provoked with complications like transitory risk factors, you should extend it. Unprovoked, we extend it. Patients with high risk of bleeding, we treat for less time. Distals, we can treat for 3 months. Cancer, as long as cancer is active. Upper limb, we treat for prolonged period. And those guidelines are kind of very dynamic, and they're going to change in the upcoming months. Unfortunately, we have lost Dr. Clive Kieran, who is a Canadian enthusiast of duration of anticoagulation. And he published this very important paper in the beginning of this year that shows that when we withdraw anticoagulation strategy at any point, the risk of recurrences starts to increase again. So we expect, given the new data with DOACs, that we're going to have a more flexible and more prolonged time for VT treatment rather than just 3 or 6 months. The other thing that is very, very, very important is chronic kidney disease. I believe that we have learned, and this is very important, Sergio, the new INR for DOACs is creatinine clearance. So everybody has asked us, yeah, here you guys, you develop a drug, we cannot monitor it. Well, monitor the creatinine clearance. Why? Because we deal with fragile population, and even on the DVT realm, we see decrease in the creatinine clearance during time. And these patients, they have increased risk of bleeding, but they have increased risk of thrombosis as well. So it's an art to deal with decreased creatinine clearance. And what we have learned is that we should not adjust the dose with DOACs when we're treating a DVT, unless you're using edoxaban. That's the only one we have studied dose adjustment. And the real world data shows that there's a trend to adjust the dose by colleagues when you're treating DVT using the atrial fibrillation rule. It works for atrial fibrillation. It doesn't work for VTE. And what happens if you adjust the dose when you should not adjust the dose is 10 times more VTE recurrences without protecting your patients from bleeds. So this is something we just published. Dr. Caprini is a co-author with us for the COVID area. It's a cartoon. It's very simple with the doses for VTE management with all the DOACs, rivaroxaban, apixaban, the Bigatron. Bear in mind for the Bigatron and the edoxaban, you should use heparin prior to the treatment, but keep in mind, if you're in doubt, look at the label, look at the Google, whatever, but don't adjust the dose for these drugs unless you are using edoxaban. This is something very important we have learned. And in this slide, we summarize what are the new recommendations from the European Society of Cardiology. And there's something very important. Number one, antiphospholipid syndrome, do not use DOACs. We have changed our minds. Treat it with vitamin K antagonists. Why? Because we need higher doses. For patients with no identifiable risk factor, persistent, or even transient and reversible risk factors, if they're there, extend the anticoagulation. After 6 months, for apixaban and rivaroxaban, you reduce the dose. You don't adjust it. You just adjust the dose for edoxaban. And now we can treat cancer-associated thrombosis with either redoxaban, rivaroxaban, and now apixaban with a beautiful Caravaggio trial Professor Giancarlo Agnelli published 2 or 3 months ago. So now we learned a lot about DOACs. We have apixaban, edoxaban, rivaroxaban, dabigatran, and betrixaban in the US. And now we are in the era of the factor XI inhibition. We're doing massive trials, and there's space for that. Why? Bleeding. Our primary target is stroke, particularly cryptogenic strokes, but we're going to study factor XI inhibition in the medically ill population, in the cancer population, in the peripheral artery disease, probably in the coronary artery disease, and there are some plans to bring it back to the atrial fibrillation population. So we have loads and loads of clinical trials coming with the factor XI. Well, what we're doing with the COVID area? Well, when this pandemic started, I thought I would stay at home and study, but I couldn't imagine that this virus was so thrombogenic. So we're doing 3 big trials here in Brazil with anticoagulation. Number 1 is called the ACTION trial. It's a collaboration with our Duke folks. And we're testing the hypothesis that giving full anticoagulation for patients at the hospital with high D-dimer levels will improve survival. We're comparing full anticoagulation either with heparin or rivaroxaban 20 for 30 days versus a standard prophylactic regimen, 600 patients, primary endpoint mortality. Very important trial. We have enrolled already a fair number of patients. The other one is called the Michelle trial, Sergio. It's led by me. We're replicating the Mariner trial for these patients who are leaving the hospital with high D-dimer levels. What should we do with them? We're giving either rivaroxaban or nothing, and we're doing angio-CT scans on day 35, plus a very thorough duplex scanning of upper and lower limbs, and we're collecting loads and loads of biomarkers. Hey, Dr. Caprini, Tafur is working with us. We're using both the IMPROVE and we're using the Caprini score as well. We're going to compare them when we discharge these COVID patients. It's a fair number. It's 320 patients. We're about to start randomization in 2 or 3 days. Then we're doing a very interesting trial called the CARE trial, where we're giving rivaroxaban versus nothing for these patients who are at home, but very symptomatic for COVID. And our primary endpoint is also survival, but mainly to reduce the need for hospitalization. And we have a big question mark to what do we do with these patients that doesn't answer even to RTPA. We're seeing at least 1 or 2 arterial thrombosis COVID related a day here in the academic center I work with. We're seeing this very severe and dramatic phlegmasia ceruleus dolens, arterial thrombosis, strokes, myocardial infarctions. So what we're doing? Well, this very important paper from New England showed that the virus destroys the endothelium itself, and it's a primary endothelitis. So we're testing 2 strategies. we're starting a trial called STRUCK trial, where we're looking at IL-6 inhibition. We're going to take it out. We're going to use colchicine, but our primary evaluations, IL-17 inhibition and lower dose of IL-2, which is super anti-inflammatory drugs for survival for this very sick population. And patients with primary pulmonary hypertension, we're vascular surgeons, so we're testing alprostadil, which is prostaglandin. And since we have some experience in those thromboses, and these patients, they don't respond to even our TPA, we're testing that we can reduce mortality in this very sick population with alprostadil. So these are the trials we're running in the middle of the pandemic era, Sergio. I think this phrase from Edwards Deming, a data scientist, is that without data, you are just another person with an opinion. And I don't know in Italy or in the US, but here in Brazil, we're seeing a lot of millions of physicians giving their opinions on the WhatsApp Journal of Medicine. And I think we're very polarized, and I'm a big fan of randomized clinical trials, particularly and most importantly in the pandemic era, Sergio. So that's my presentation, and I'll be happy to take some questions.
And thank you so much for truly an outstanding presentation, and also for touching the topic of evidence-based data. As you know, we are always trying to deliver initiatives that are indeed based on evidence-based data. And we deeply thank the Continental Expert representative that indeed in an evidence-based way will make questions to you. And it's my deep pleasure to start from Costa Rica, where we actually met for the last time in person, Eduardo, together with Dr. Lorena Grillo, who we should also congratulate for the outstanding performance in yesterday's initiative dedicated to gender equality. Lorena? Lorena, we cannot hear you.
Yes. Good morning. Thank you, Dr. Achati, for an excellent talk. And I was very interested in the last COVID trials, because there's in Costa Rica here, for example, yesterday we had 950 new cases, and they are posting as positive the close nexus patients as highly suspected COVID patients. So my question is regarding this. In the scenario of a venous thromboembolism patient who is about to finish the anticoagulation time, but has a close epidemiological nexus with a COVID positive patient tested, would you consider an extension of treatment?
Well, Lorena, a very nice question. From a puristic standpoint, a provoked DVT by COVID, it's a provoked DVT and you can treat it for 3 to 6 months, correct? But as a matter of fact, we don't understand this virus. We don't know if the endothelial damage keeps it prolonged for 3 months or 6 months. So what we're doing now is we're recommending to give us a little bit of time to gain some knowledge on that. And if you have the suspicion that there is a high risk of recurrence, keep this patient anticoagulated for a little bit more prolonged until we get some data. So what we're doing, we're collecting, since we're seeing loads of venous thromboembolism related to COVID, we're doing the endothelial test with the ultrasound. I have a cardiologist doing that in this VTE provoked in COVID patients without other risk factors. So as for now, our small anticoagulation community is recommending that do not consider it just provoked. Prolong a little bit and give us a little bit of time to gain more data.
Thank you very much.
Thank you so much, Lorena. And now we fly all the way to Japan, and it will be Professor Bottini introducing the Continental Expert representative, who also prepared some interesting slides. So, Oscar?
Okay. It's my pleasure to introduce Dr. Mo Makoto, professor at Yokohama University. Thank you, Dr. Makoto, for the excellent teamwork we are doing together for a joint Latin American session and the next meeting of the Japanese Society of Phlebology in September. Dr. Makoto, whenever you are ready.
Thank you very much.
Yeah. If you want to share your screen, Professor Mo, that's great.
Yeah. So I have a question. Thank you very much. Thank you very much for great lecture. It is very informative. And I have a question. And higher normalization of the combined venous ultrasound and the CT lung imaging in DOAC patient, in Japanese patient demonstrated. And 6 months later, normalization by rivaroxaban is 56%. And warfarin, with warfarin, the normalization is only 31%. And also there is a Brazilian study, RCT, in proximal DVT, drug versus warfarin. It demonstrates PTS at 1 year is with rivaroxaban is just 8.7%, but warfarin is 28%. And also total recognition was rivaroxaban is just 78%, but warfarin is just 13% or 13%. And there's a huge difference in the result. And I have a question. The preliminary data suggested drug may contribute to better normalization of the vein and the decrease of post-thrombotic change. And do you think this phenomenon is a real phenomenon or just fake? And if you think so, what is the nature of drug contribute to these results? Nature of the drug itself, or just a higher quality of the anticoagulation? Thank you very much.
Well, this is a very nice question, Dr. Makoto. And our group at Loyola has published this information regarding the correlation between early recanalization and rivaroxaban. And Dr. Farid, who is my super friend from there, we have been asking this question as you did. So we took a look at the Einstein program, and we could recall some of the patients, and we showed that patients treated with rivaroxaban had 32% less post-thrombotic syndrome using the Villalta score, but it's non-significant because of lack of sample size. We don't know. Probably it's both of them. Number one, 15 BID for 3 weeks is a massive anticoagulation strategy for rivaroxaban. So our theory is that massive anticoagulation at the very beginning of treatment helps, and the quality of anticoagulation as well. If fibrinolytic action, we don't know. We really don't know. But as of now, we could just see this trend with rivaroxaban. It's not a class effect. We never had the chance to study apixaban or edoxaban patients to see if it is a class effect or not, but it's real. So everywhere I go in the world, people are saying, hey, Professor Ramasciari, I'm treating patients with DOACs. The recanalization is faster. Well, Jose is studying in his lab this fibrinolytic action. I'm aware that these drugs do have a very tiny fibrinolytic action. So our theory is that you have already answered. It's the quality of anticoagulation plus this massive dose of 15 for 3 weeks. This is our theory. What I'm doing very interesting is that there's a theory that it happens also on the arterial side. So we are just starting a trial with rivaroxaban 2.5 BID plus aspirin for intermittent claudication. So if it's true that reopens vessels, then we're going to see some effect in the functional part of peripheral artery disease. There's just one to prove that. It's a proper sample size clinical trial, and we're just starting the COMPASS claudication study this week as well. So thank you for your very, very nice question.
Thank you so much, Professor Mo. And now we fly all the way to United States. I wish it was me introducing him because he's a dear friend, but it will be Professor Chi introducing the Continental Expert Representative. Willie?
Yep. Next, we have a leading figure of the AVF, Dr. Patrick Muck, who's also the Chief of Vascular Surgery, the Program Director of the Vascular Surgery Fellowship at the Good Samaritan Hospital in Cincinnati. Dr. Muck?
Thank you so much, Sergio. Great job, as always. Jose and Eduardo, incredible presentations. Eduardo, your command of the DOAC literature and your research in the COVID-19 pandemic is inspiring. So I have a very practical and yet personal question for you on a clinical scenario. I have a very dear friend who has metastatic colorectal carcinoma. 8 months ago, he was diagnosed with a femoral popliteal DVT, and he's been on full dose Eliquis for the last 8 months. Unfortunately, due to his metastatic disease, he has back pain. He refuses to take narcotics, and he's on NSAIDs for that. However, unfortunately, he's not been taking his NSAIDs due to bleeding concerns being on full dose Eliquis. So my question to you is clearly the world expert, is there any literature or any support for half dose therapy in this situation so that he would be able to use his NSAIDs and get some relief from his back pain?
Well, Dr. Patrick, as you are aware, the Caravaggio trial studied the dose of 5 BID for cancer patients. And it showed that there is no increase in gastrointestinal bleeds as we saw with the Doxaban and Rivaroxaban. But the dose studied is 5 BID. So if you are concerned with bleeding, I advise you to switch to low molecular weight heparin. And what we have studied is dalteparin, and we have dalteparin in the US. I know it's not comfortable, but if you are concerned, particularly with gastrointestinal bleeds, then switch to dalteparin. Or keep it 5 BID, because we cannot guarantee you that decreasing the dose to 2.5 will protect him. However, there are 2 studies ongoing, reducing the dose of Eliquis to 2.5 BID after 6 months. 2 of them are in the United States, and colleagues are confident that decreasing to 2.5 BID is enough after 6 months. So you have these 2 things. You can either switch to dalteparin or reduce the dose to 2.5 BID, and this is what we're doing right now. We don't have data, but we're studying right now.
Excellent. Thank you so much for your opinion and great presentation.
Thank you so much, Patrick. And now it's my pleasure to introduce the Continental Expert Representative for Europe from Poland, Professor Urbanek from Silesia University. He needs absolutely no introduction, so I will use this chance to thank him once again for his role as keynote speakers in previous Food for Veins webinar. Thomas?
Thank you very much, Sergio, and I would like to thank for this wonderful lecture. I saw Professor Eduardo last time in person before the COVID era, and I hope this will happen again soon. However, I wanted to ask you a very practical question. We know that patients with antiphospholipid syndrome are treated mostly with warfarin currently because of some contraindications to DOACs. But the question, what about other thrombophilias, protein CS deficiency, prothrombin gene mutation, factor V Leiden? What's your opinion about using the new drugs in this clinical scenario?
Well, Dr. Urbanek, it's not my opinion, but it's the data. You can use it for all other thrombophilia states. Dr. Harry Biller just published a very nice meta-analysis on that. So our concern is with the antiphospholipid syndrome, and we have concluded that it's not that DOACs doesn't work. The dose we have studied for DOACs is not enough for antiphospholipid syndrome. So switch to vitamin K. For the all others, including factor V Leiden and factor 2, you can use DOACs, no problem at all. So just switch for antiphospholipid syndrome.
Thank you. Thanks.
And thank you so much, Thomas, and thank you so much to all the Continental Expert representatives. So now, Eduardo, we move to the audience. And so in the question and answer box, we are seeing that your neighbor from Brazil, Professor Fabricio Santiago, who we thank also for having been a keynote speaker in previous Food for Veins webinar, is asking you, in terms of practicality, until these trials show their result, what is your current advice regarding doses of low molecular weight heparin in COVID patients?
It's very simple. Follow the guidelines. Follow a CSP guidelines, follow our IOA guidelines, and don't invent the wheel. So if you have a in-hospital, hospitalized patients, high Caprini score, high improved score, keep the doses of injectables. In the US, you can use Rivaroxaban. It is approved for in-hospital prophylaxis, but not ex-US. We're gonna prove it here in Brazil. So use the regular dose. If you have an obese patient, then you can double the dose. And if you have a creatinine clearance decrease, you can cut in half the dose. Doubling the dose of heparin without data did not show improvements at all. And we lost some patients due to intracerebral hemorrhage. We lost a 38-year-old pediatrician colleague here because of increased dose of heparin, and it's not justified. Having said that, and what we're seeing in the front line, and I'm a scientist, but I'm totally on the front line. I'm on call for the ICU thrombosis patient in the medical school. I'm a professor. I'm seeing loads and loads of patients. So if you have a suspicion of DVT, then you have a situation that you should give full heparinization dose for these patients. If you're in front of the patient, and I'm not in front of the patient when I'm doing the trial, if you feel that heparin will help, then use them. Professor Narula just published an observational study where they showed 15% reduction in mortality for patients on ventilators that received full anticoagulation strategies. It looks like it's the way to go. And we're gonna have the results for the ACTION trial in 2 months, maximum in 2 months. We're speeding up the study. It's robust, 600 patients. We're gonna have this answer. But as for now, follow the guidelines. Do not create doses because it's not just my personal opinion, but I don't think that the pandemic state is a situation where you should create doses because you are desperate. I understand the colleagues who are on the front line, and there's a very important New York Times article discussing that. And my dear friend Alexis Spiropoulos is the main character of this article. And he called one of it was a discussion in terms of doses of heparin. And he said that creating those is kind of witchcraft, even on the pandemic state. So simple message, follow the guidelines, all the data we have for viral infections of the lung. As for now, until we have time to generate proper data. There are, as of now, 49 clinical trials ongoing with anticoagulation strategies for COVID patients.
Thank you so much, Eduardo. And now, thanks to Professor Rashad Bishara, Egypt goes on the podium of the questions once again. So it's an excellent presentation. Do you think that the steady level of anticoagulation provided by NOAC, as opposed to vitamin K, could reduce the severity of PTS following DVT?
Well, we have discussed that with Dr. Makoto. I think so, but the only drug we have proved is rivaroxaban. I'm not sure if the other DOACs can provide that reduction in post-thrombotic syndrome. And bear in mind that our criteria for post-thrombotic syndrome is a kind of using the Vilauta score, which is not very sensitive to show this correlation. So in order to prove it, we need a proper randomized control study, but observational data from both the Einstein program and the Japanese data and this randomized clinical trial in Brazil shows that there is a trend to reduce post-thrombotic syndrome.
Okay, and we fly once again to India with Professor Rahul Jindal. The role of DOAC at present for COVID patients, or should we use low molecular weight heparin?
Can you repeat, Sergio?
Is there a role for DOAC at present for COVID patients, or should we use low molecular weight heparin?
The role for DOAC is exactly the role for non-COVID patients. So you can use in-hospital prophylaxis, the injectable drugs, and you can extend the prophylaxis based on the Mariner trial with rivaroxaban. And if you're treating a DVT, you can treat your patients at home, and you can use DOACs, all of them, to treat either deep venous thrombosis or pulmonary embolism in the COVID area or out of the COVID area, as long as you follow the label. So there is a role, yes, and we are studying right now new data for it.
Okay, so if the camera is still working, Eduardo.
It's working.
The next question is from Dr. Fabio Rossi, and he's saying, congrats for the nice presentation. Is there any indication or situation when aspirin should be added to DOAC in the long-term DVT treatment? What about after vein stenting?
Well, Dr. Fabio Rossi is an enthusiast of vein stenting. And as of now, Sergio, all the experience we have for using antiplatelets and anticoagulation in combination for stents comes from the cardiology realm. So we have very interesting trials that was focused in safety. The Pioneer, the Augustus trial, we did the Augustus trial with patients with atrial fibrillation and needing stents. It's 4,800 patients, very robust data. And look at that, what we have learned. Dumping aspirin, keeping DOACs plus clopidogrel is the best strategy. That's the way to go for patients needing anticoagulation plus antiplatelets. So my question back to Fabio and to these guys who are enthusiasts of stenting veins that do we really need antiplatelets? What are the trials that showed any benefit on that? So we need randomized control trials, and I'm aware Fabio is doing that. So as of now, we're exporting our experience from the cardiology realm. We're dumping aspirin and we're keeping clopidogrel.
Okay. So Dr. Melissa Moraes is asking you, I would like to know what is the best conduct in the management of the patient with the recurrence of a thrombotic event in the correct use of NOACs, changing drugs within the NOAC group or using warfarin?
Well, what we did in our trials is that we left at the discretion of the investigator what he should do in terms of recurrence. I believe, who asked that, Sergio? What's her name?
I have to go back, sorry. She's from Brazil.
Well,
it's in the middle of many others, so I cannot see that anymore because it's
Melissa,
okay. Melissa Moraes. Melissa Moraes.
So Melissa, first reason for recurrence is not taking properly the medication. That's the number one reason for recurrence. We have observed that with a lot of criteria in our clinical trials. So that's the number one. Number two is baseline disease, cancer, thrombophilic states, crazy disease like hemoglobinuria, paroxysmal hemoglobinuria. So number one, check if the patient is compliant to the therapy you're providing. Switching to heparin is something we allowed in our trials, or increasing the dose of an anticoagulant like rivaroxaban. You go back to 15 BID for 3 weeks. So you consider a new index event. We took a look in what happened in recurrence rates with both strategies, no changes. So you either switch to heparin because of the anti-inflammatory effect, or you increase the dose of your drug. It doesn't change the posterior recurrence rates. But don't move back to warfarin unless you have a good reason. And the only reason that happens to me is antiphospholipid syndrome.
Okay, Eduardo, we are running out of time, but if we are not taking the one of Annalisa Rodriguez, I think she will be angry with you. So we'll just take this last one. And she's Annalisa again. We know many colleagues have been prescribing anticoagulants for non-hospitalized patients with COVID, despite their severity or comorbidities. What's your opinion about preventive use of anticoagulants for these patients?
Well, we're doing the CARE trial. So we're taking a look at the COVID patients who are at home. They were supposed to go to the hospital, but our hospitals are so packed that we're keeping a fair number of patients at home. And we have some patients with high D-dimer levels at home. So my answer is we're doing the CARE trial. 1,000 patients. Our primary endpoint is survival. And then number two, decrease the need for hospitalization. We don't know, but I can tell you, I think 30 vascular surgeons in my country got COVID. They all called me, and they all took anticoagulants at home. All, 100%. My p-value is extremely significant for that. But as long as we don't have data, I cannot do recommendations. But okay. I would take myself. That's my direct answer for you.
Eduardo, thank you once again for a truly stellar performance, and the same for Professor Diaz and all the faculty involved. Now we move toward the end, and we are almost there also with Food for Veins, because as you know, next Sunday will be the last one. So we thought about having some surprises for you, since these are the, let's say, semi-finals. And since the WIN Foundation is actually strongly focused on the topic of the venous thrombosis, indeed we answer to the call of Lancet about DVT being a leading cause of preventable death, and I take this chance to deeply thank all the colleagues who have been also involved in another project we developed for the patients on COVID, and I invite everybody to see that on the website. The surprise is a huge honor we all are enjoying today in the person of the Colonel Professor Paul White. Professor White is, first of all, a dear friend, but also a wonderful example of professionalism. Is in an outstanding center, the Center of Norman Rich at Usus Bethesda. There is no need for introduction of one of the fathers of modern vascular surgery. So I asked him to provide to us 3 golden rooms from the field in venous thromboprophylaxis in trauma patients. And here is his contribution, and later on we will have him also live.
Hello, my name is Paul White. I'm an associate professor of surgery at the Uniformed Services University of the Health Sciences in Bethesda, Maryland, and the program director for the Vascular Surgery Fellowship at Walter Reed National Military Medical Center. I want to thank Professor Sergio Giancini for inviting me to relate our experience with DVT prophylaxis in the U.S. military, share a few pearls. Dr. Giancini has been a true friend of Walter Reed and Uniformed Services University. It's an honor and a pleasure to be asked to participate in this conference with its dual roles of education and charity. As you well know, trauma patients are particularly susceptible to venous thromboembolism. There is a real challenge in treating these patients because one has to balance the very real risks of hemorrhage with the equally grave risks of venous thromboembolism. Dr. Gertz et al. Reported that VTE may occur in nearly 60% of trauma patients without prophylaxis. We also know that once the trauma patient has been hospitalized, VTE becomes a leading cause of death. Dr. Knudsen and her colleagues describe specific risk factors for trauma patients, including age, lower extremity fractures, venous injury, shock, major surgery, head injury, and greater than 3 days of mechanical ventilation. Our combat injured patients over the last 2 decades have also had some unique risk factors for the development of VTE. These include frequent massive transfusions, use of old blood, long evacuations by airplane within hours after injury, and amputations, often multiple amputations. In the early 2000s, we were surprised by the frequency of venous thromboembolism in our patients evacuated to the United States. VTE prevention was one of the earliest goals of the Joint Trauma System Clinical Practice Guidelines. Groups at both Brooke Army Medical Center in San Antonio, Texas, and Walter Reed Army Medical Center in Washington, D.C., also evaluated their experiences. I wanted to share some of the key lessons we've learned. First, chemical prophylaxis for VTE should be initiated very early. Most DVTs were discovered during evacuation or within the first few days of hospitalization. We currently recommend that chemoprophylaxis start as soon as any concerns for bleeding and coagulopathy have been addressed, ideally before 48 hours after injury. Even patients with head injuries can usually be safely started on chemoprophylaxis, although close consultation with a neurosurgeon is necessary. Another concern with polytrauma patients, especially those injured by blasts, is frequent return trips to the operating room. It's important to maintain regular dosing schedules of chemoprophylaxis throughout hospitalization, despite return trips to the operating room. Patients who miss greater than 50% of the doses have a rate of venous thromboembolism more than 3 times as high as those who receive regular doses of low molecular weight heparin. Lastly, we found that low molecular weight heparin was more effective as chemoprophylaxis than unfractionated heparin. In their chest publication, Hawley et al. Reported VTE rates of less than 3% in patients who received noxaparin at 40 milligrams sub-Q daily or 30 milligrams sub-Q twice daily, while VTE rates were greater than 10% if unfractionated heparin, either TID or BID, was given. Thank you very much for allowing me to share some of our experiences. Again, I'm very grateful to Sergio for the opportunity to participate in this conference. Thank you.
So we deeply thank Professor White, who should be with us in this moment. So Professor White, can you unmute yourself?
Yes, Sergio, I'm unmuted.
So thank you so much for your contribution. We are all honored, and we truly hope to have you with us in our meetings very soon, where we will go back in person. So I will take this extra minute we have just for a question for you. In 2013, they published an interesting Cochrane revision on VTE in venous trauma, and they were writing we should use any prophylactic measure for VTE. So how would you approach compression, and in particular intermittent pneumatic compressions versus graduated compression in this kind of trauma?
Thank you very much. I think it's a great question, and really something that I sort of skipped over for time constraints, but agree completely. I think compression devices, intermittent compression devices, should be initiated immediately when a patient is admitted to the hospital in a trauma situation. So in addition to chemoprophylaxis, sequential compression devices are absolutely important.
And in 1 second from now, we will enjoy the wonderful contribution of Professor Caprini himself. We all know he's a score, and recently there has been a publication about its adaptation for COVID. Would you say that in these trauma patients, we should always suppose to have an asymptomatic positive, so give 2 extra points, and should change something in our approach to these patients, maybe a shorter surveillance, or how would you approach this phase of COVID with trauma?
I think that we should treat them the same way we would treat non-trauma patients. So, you know, at least in the United States, at least at Walter Reed, we're testing all of our patients who are being admitted to the hospital to prevent intra-hospital spread of the virus. And if those patients are positive, I think it's reasonable to give them the additional 2 points in the Caprini score and treat them similarly. Although almost all of them, again, we recommend, highly recommend both SCDs and chemoprophylaxis as soon as possible.
So once again, deeply thank you for the huge honor of having you with us, and I truly hope this is just the first of many other chances in person with our group. So at this point, we move from one honor to the other, because now we have the huge honor of Professor Caprini himself. No needs of introduction, but I like to take this chance to deeply thank him, not just for being a wonderful example in the professional field, but also in the public health awareness field. You see him over here with a t-shirt that is saying, never kill a friend, never treat a stranger. He will explain you why. And it's time indeed for the take-home messages from the honorary chairs, starting from Professor Caprini himself. Joe, the mic is for you. Joe, unmute yourself. Khaled, do we have Joe? Ready?
There we go.
Yeah, here we are.
Thank you very much. It's a great honor to be here, and I appreciate all the kind remarks, and including me with these brilliant investigators. I'm having a little trouble after listening to these presentations about coming up with an appropriate superlative remark. These were unbelievably outstanding presentations, and we'll start with Jose, who's a very dear friend and a magnificent surgeon and researcher. He has the whole package. And he presented, as was asked for this entire assembly, to give the basics of coagulation and a very practical discussion regarding the coagulation cascade and how the individual risk factors interact to eventually result in a thrombosis. And I would point out that his discussion regarding Virchow, a pathologist who described the 3 factors, blood coagulation, stasis, hypercoagulability, and vascular injury, as important mechanisms, should be of great interest, because although these factors were presented in 1856, they're just as important today as they were forever. And it's a challenge to the young people. Don't forget the literature. Much of the past literature is sitting there, and if you don't know it, you're going to have to reinvent it. And he also illustrated how and where the anticoagulant drugs affect the clotting cascade. His discussion continues regarding the discussion of important concepts regarding deep vein thrombosis, pulmonary emboli, and an interesting discussion regarding the mechanisms in the genesis of venous thrombosis. I'm sure the audience will be fascinated regarding how the incidence of deep vein thrombosis relates to the age of the patient. There again, it's an incredibly old concept that goes back to Gunnar Bauer, even before Andrew Nicolaides. And it's really important that one recognize those issues that he brought to our attention. Interesting data regarding mortality, recurrence of blood clots, and the post-thrombotic syndrome. He also touched upon as being as well as the uncommon but really difficult issue of chronic thromboembolic pulmonary hypertension, which is another enigma which we really have talked about. Finally, he discusses the role of anticoagulation therapy in the management of this disease, and this is an incredible segue to the next presentation. And Eduardo, I find it very difficult to tell you how brilliant this was, not only from the content, but your command of the literature. I don't think, is it true? You don't go to sleep, do you? It's impossible for you to go to sleep because you're on the front line, you're on call, you're involved in every important trial, and you know the latest literature almost before it comes out. And it's just astonishing. And the way you describe the highlights of preventing recurrent VTE events and the phases of anticoagulation treatment. And that's one thing now that I think that you're pointing out, you're hinting at, which is something I've believed in for a long time, is the differences between provoked and unprovoked. That's very artificial. And the idea that you give people anticoagulants for 3 months and you stop, I have no, I'm glad that you brought that up, because I've never done that. And we always take a very careful look at patients with residual thrombosis and so forth. I don't want to give my own speech here, so I won't say any more about that. But you're stimulating us to break down all of these previous barriers. And by the way, with data, which is really incredible. Your beautiful set of diagrams showing the prevalence and impact of appropriate and inappropriate dosing of these drugs was really very impactful, as well as your presentation on the European Society of Cardiology recommendations for chronic and extended treatment to prevent recurrence of the patients without cancer. And then your comments on COVID. And I think that it's very important, the really salient things here, which I think have to be emphasized, is the fact that these patients are at increased risk when they go home from the hospital, and why the authorities didn't already endorse Mariner, because Mariner worked for non-COVID patients. Well, COVID patients are much higher incidence of thrombosis. So why in the world wouldn't you recommend it? They're not of lower, but of higher risk. Now, I'm glad to see that you're throwing in Caprini score, because it's not about Caprini, it's about the most comprehensive history and physical available today. And the more things that you look at, the more things that you will be able to pick up in the patient. And I think that that's really important. And I would encourage you to include the Caprini score in the other trial as well, of those patients that you're sending home, because I think you'll find that if you do a good history and physical, you'll find plenty of reasons to do that. 2 more things I want to say. You stimulated me so much for all of these wonderful things. But one thing is that if you have a COVID-19 patient, and we firmly believe this, and that Caprini score is over 8, that means they have elevated BMI, they have other risk factors, past comorbidities, past heart failure, hypertensive valvular disease. Those patients need a higher dose of anticoagulation if they don't have COVID. So why wouldn't you give them that to have COVID? On the other hand, I quite agree with your reluctance to have everybody just splashing out all these anticoagulants, because with this disease is an embodiment of the tangled hemostatic web of Oscar Ratnoff, triggering clotting, fibrinolysis, platelets, complement and kallikrein activation. So anticoagulation isn't going to do the whole thing. And I also really want to say that I applaud your emphasis. Factor 11. Factor 11 is going to be a giant thing going forward, with improved or just as great anticoagulation protection with a lower incidence of bleeding. So I'm sorry that getting carried away with this, but I blame you, Eduardo, from having me get carried away. And then before I finish, I'm sorry for this, but I can't help myself. Dr. White, bravo, bravo, bravo. We're very indebted for this important discussion regarding our valiant veterans who are in harm's way to help us to protect all of us. Incredibly important principles. The early administration of anticoagulation. It's absolutely vital. And that's true for all of these patients, but especially for COVID patients, especially for those patients who have trauma. One must remember that bleeding events can usually be handled, but if anticoagulation is stopped, the patient can die of a thrombosis. And the idea of maintaining adequate dose schedules, and oh my God, just because you're going back to the operating room, I got to stop the anticoagulants, that's nonsense. And I'm glad that you're pointing that out and emphasizing that to the surgeons, because it's very, very important to maintain these continuity. The other thing is, you very likely, I like all of your reasons for using low molecular weight heparin instead of unfractionated heparin. One more thing that I would add is, remember that the incidence of heparin-induced thrombocytopenia is over 2% with unfractionated heparin, where it's 0.2% with low molecular weight heparin. So that's another thing that I would like to emphasize is really, really important. And so bravo for all of the work that you've done with that and the military. And then I want to close with one other thing that I think that is important, and I'm a big believer in this. Know the literature, the past literature. And we know that there was data presented, and I'm having a mental block right now, who did this, but low molecular weight heparin continuously for 3 or 6 months instead of Coumadin, and the incidence of the post-thrombotic syndrome was decreased as a result of that. And one of the things that I think happens with these new anticoagulants is very quickly after you give that anticoagulant, that patient is fully anticoagulated therapeutically. And as a result of that, it allows the body's fibrinolytic mechanisms to immediately begin to work. And we know with low molecular weight heparin and Coumadin, the ups and the downs and the unevenness of the anticoagulation in the beginning. And I think that's a critical effect. So I would like to see this studied properly. In order to study it properly, you not only have to look at the Volatil score is probably the bottom of the barrel as far as looking at this. You have to sequentially follow these patients like we did and look at resolution of, you have to do their duplex scan and resolution of their changes in the scan. You also have to do physical examinations. You also have to make sure that they have adequate pneumatic compression with stockings during this period of time and other quality of life scores. So I'm sorry I'm getting carried away, but this has been a fantastic program. And I think that my enthusiasm is justified based on the quality of investigators. Oh, and bravo to the Japanese. What a fantastic presentation. You know, I'm sorry, I'll stop now. Thank you very much, Sergio.
So, I have your same issue. I cannot find a word to express the gratitude we all have for your participation and your always stellar contribution. So thank you so much. And now it will be a real deep trouble for Professor Henke from the University of Michigan to perform after such a performance of yours, but in reality it's not a problem for him because Professor Henke is actually coming from the temple of the coagulation investigations from the University of Michigan. He's a stellar colleague, so I'm sure he will have some precious insights to give to us, and I deeply thank him for joining us. Pete, the mic is for you.
Yeah, thank you so much, Sergio, for inviting me to this great webinar, especially kind of last minute, and I'm honored to be on this great panel. It's good to hear from Jose, and we worked together for many years here, and Eduardo in the Jobst lab as well, so a lot of connections here. And appreciated Dr. White's talk as well. So it's always hard to follow Joe with regards to enthusiasm, but again, these were very cogent talks. I think it's really a timely topic, obviously with the pandemic that was highlighted by Eduardo. Just a couple thoughts and take-home points that I got or would like to make. Number one, and I think Joe hit this nicely as well as others, that really it's provoked versus unprovoked is false, and DVT is really a chronic disease. So once you have it, you always have it. And I think the prolonged treatment with these safer agents is really the way to go unless there are significant bleeding risks. I think as Jose highlighted, inflammation and thrombosis intersect and often promote one another. Things to keep in mind besides viral illness is other bacterial infections, and they increase the risk of hospital VTE by at least 2.5-fold, urosepsis, that type of thing. So these are high-risk patients. Don't forget to keep extra scrutiny of them when you prophylax them. With regards to that, many times patients are adequately or hopefully risk assessed, get the appropriate prophylaxis, but then they have this breakthrough VTE that we've had an interest in recently. There can be multiple factors for that, but there are probably some true biologic breakthrough VTE, highest Caprini scores well above 11. Maybe that's a role for empirical anticoagulation. I think a trial is needed there really, hopefully soon. I think with regards to post-thrombotic syndrome, it's kind of the less sexy aspect of venous disease. It's fibrotic disease. It's something we've tried to study in animal models, and Jose is certainly the world's expert on models for venous DVT. And really, it's vein wall injury. So we're looking at, and hopefully and others across the world, particularly in Germany, the role of leukocytes and monocyte macrophages, and whether these could be skewed in some way to promote healing of the vein wall versus continued inflammation that leads to irreversible fibrosis, I think is an area of, could be high impact. With regards to DOACs and PTS, I think it's kept out of the bag a little bit. With regards, since most patients will be treated with DOACs, I think we'll probably see a decrease in post-thrombotic syndrome epidemiologically over time. I don't think there specifically has to be a trial related to this because DOACs are so commonly used. And again, like Joe said, have that early rapid onset of anticoagulation and less fluctuation as long as they take their medication. With regards to statins, I think that there is real potential there. And I know there's one trial at least going on in Canada looking at this for post-thrombotic syndrome prevention. And, many of the patients, like Joe said, are elderly or old. Age plays a role, and if they're already on a statin, may not get afforded additional benefit, but maybe the younger patients, 40s, 50s, who have aggressive VTE or DVT may benefit from a statin. Note that also the PCSK9 inhibitors, there's a report out, I think, in Circulation that suggested these may impact incident venous thromboembolism as well. I'm sorry, I forgot the name of that trial. So from Eduardo's really outstanding summary, I think the factor 11, like Joe said, is going to be important. That'll be really exciting to see. Really excited to see your COVID trials. You've rapidly got that going in South America. That's outstanding. The NIH has 3 major similar type trials. I don't have time to go into those, but they're getting rolled out in a little bit slower fashion. I will say at University of Michigan, we do treat in our ICU the highest risk patients who are sickest in the unit on the ventilator with empirical anticoagulation. We've been following this. We published a short article in JVS VL about this, and we've been tracking bleeding complications that have not seemed excessive at this point. Lastly, with regards to trauma, certainly low molecular weight heparin is the standard. I wonder long-term, could you use a low-dose DOAC for prophylaxis in the trauma population as a potential trial? And lastly, the role of filters seems to be diminishing in trauma patients empirically, which I think is a good thing because most can be treated with anticoagulation. Again, Sergio, thank you so much.
And thanks to you. And we take this chance to mention Russell Hound's work that Professor Caprini was writing to us. Now we have it as well as information. And now we move forward toward the end with Professor Liu NC, a dear friend from many of us, a huge expert from Putra University in Malaysia. So it's our deep honor to conclude with his final remarks. Professor Liu.
Thank you, Sergio. Now, this presentation is timely because anticoagulation has again rose to prominence in the recent COVID crisis, where thrombosis in both arterial and venous bed is accentuated. Now, health authorities all over the world are stocking up on these life-saving medications, just like they do the PPEs and the ventilators. Now, as a person who is interested in thrombosis, we have often been asked what is the best prophylaxis or treatment for seriously ill COVID patients in an intensive care unit. We know thrombosis of artery and vein is a frequent occurrence in this patient. There's really a thin line between treatment and prophylaxis in the usual sense. We prevent venous thrombosis, but in COVID patients, do we prevent or do we assume concomitant arterial thrombosis since we can make a diagnosis soon enough? And what have I learned today? I think from DIAS, I think it's interesting that heparin was first discovered sometime in 1917. It's about the time of the first Spanish flu pandemic. And maybe in about 100 years' time, there'll be another pandemic, and people remember that this pandemic occurred about the time when DOAC was actually introduced. In Asia, the epidemiology of VT is also changing. The incidence is actually increasing. The only issue in Asia is the dosing, because there are reports suggesting there's actually a slight increase in the bleeding risk in the Asian population. There's still a lack of data on the issue of the ethnic variation in the bleeding risk. And so I think we still need more studies to look at that. Eduardo gave a very good presentation on the DOACs. And on the whole, the conventional method has been to use either unfractionated heparin or low molecular heparin or fondaparinux followed by vitamin K antagonist. The newer approach has been to replace vitamin K antagonist with DOAC, and in some instances, DOAC such as rivaroxaban and ecsplantin could be used as a monotherapy. What is contentious is actually the duration therapy. Now we know there are 3 instances where there are good supportive evidence of type 1B. That is in those with unprovoked DVT, treatment for at least 3 months. In provoked DVT and with low bleeding risk, consider an extended therapy. And those cancer patients, also extended therapy when the cancer is still active. I'd like to comment a bit on what's said by this Colonel Paul White. The talk on the 3 basic principles to follow on trauma is really enlightening. It is ironic that seriously traumatized patients have both a high bleeding risk due to their injury and blood loss, and again, high thrombotic risk due to their innate defensive mechanism of arresting bleed. Now, making a treatment decision on the hostile environment is difficult enough. Balancing the thrombosis and bleeding risk is equally challenging. Now, managing these patients does not based on knowledge alone or the skill sets alone. We also require decision, and that's often difficult in an unstable environment. And I've been UN peacekeeping missions before and working in the field hospital, and I remember if someone asked me, why did you manage the patient this way? My answer often is, I did it this way because I was here. I'm glad Paul White has simplified the algorithm for us, the 3 simple steps, and we could do away with concomitant indecision, often euphemistically described as constant paralysis, often lead to paralysis. I enjoyed this webinar very much, and certainly I've learned a lot, and thank you very much.
And it's me and Win deeply thanking the honorary chairs who have been involved in this final part. We made the exception of taking extra 10 minutes. I'm sorry for this, but it was exceptional to have also Professor White. So we really want to thank him once again. I will leave the mic to Oscar and Willie for the final remarks. Oscar?
Nothing more to say. It's really interesting topic discussed today as it is anticoagulation. Dr. Ramaciotti, my brother Jose, thank you very much. Thank you all then for attending this extraordinary initiative for Food for Vein, Vein for Food, Sergio and Willie, until next Sunday.
Thank you, Oscar. Willie?
Well, great lecture from Eduardo and Jose. Thank you for all from attending. Good morning, good afternoon, good evening.
And thank you once again to everybody. We are going to the end, so deeply thank to all the ones who have been involved. I deeply thank once again the keynote speakers as well as Professor White for the outstanding performance and also for their time in answering the questions that weren't answered today in live. So during the week, we will post them on the website. Next week will be the grand finale. We will dedicate it to the lymphedema part with the great figures from the International Society of Lymphology and huge experts from the field in general. I take this last chance to remind you that tomorrow is the last day to submit your abstract for the American Venous Forum meeting. And I take this chance to deeply thank all the ones who have spent this time with us today. So once again, deeply thank to all of you for being part of this humanitarian education initiative, and see you next Sunday for the last time. Ciao. See you.